So I'm Eric Engwall. As some of you might have heard, I'm very good today, all good. How about you? Very good, of course. So I am the chief physicist at Research. I've been working a lot with arc therapy, also with uprights, so we're trying to combine the things here. So what can we do with all the new potentials with arc therapy and especially in upright position? So one first thing, what we can see is that we really get new advanced opportunities with this. With the upright system now, we now can have a fixed beam line, and all the hardware improvements will be much easier. You can integrate imaging during the treatment, doing MR guided protons. That is one of the images you see here. You could even think of utilizing the magnetic field to bend the protons around risk organs. We can be better at doing online and real-time adaptive. If you like to do delivery verification, you can go for very advanced techniques and now place the detector just as a stationary place, which is of course an advantage. You can do that with radioactive sources as you saw, or the Cherenkov. All of these will be helped to do the delivery verification. But also for the planning itself and shaping the beam, we have much easier and faster changes of the hardware. So we can think about the MLCs and blocks and so on. They are now stationary. You have much higher speed of the motors, etc. With grid blocks, like in photons, much more easy with the range shifters, energy selectors, etc. You can think of anything what you can do which is much easier in an upright position. But then of course we also see that new treatments could come up. So going for not just the arcs, but also the helical arcs, where we translate upwards while rotating. Doing proton and ion arcs, which is really an emerging field right now. Start to combine treatments, right, with protons and photons, doing co-optimizations. Or you can even do protons and shoot-through protons that we will see a bit later. And then new modalities like the very high energy electrons, where you can go for flash technologies and also in normal regimes. And of course, anything else that pops up will be easier to implement in an upright solution. So what is happening really is that we're doing simplification, which enables advancement. And much of the things on the treatment technique side will be done with the arcs. So it's the arcs that can unlock many of these potentials. So I would like to give some introduction on what has been done on the static proton arc projects. So, I mean, we've heard a lot of proton arcs in the research community, but now recently we have deliveries in a clinical setting in Trento in Italy. So they have now treated 15 patients with this technique, and they see very improved dose distributions and really want to move forward to this technique. This is what they did before. So they had extremely complex field setup with 7 different field directions, some split beams with range shifters and without range shifters. And that was replaced by these coplanar arc. So much simpler, much better dose distribution. And of course, if you look at these differences, this one is very difficult to take to upright. This one extremely easy, right? So it's really the arc that paves the way. And we see that this transition, going from the gantry-based rotation to the chair-based rotation, is fairly easy. And if you also think about the size, what would you prefer, to rotate 100 tons or 100 kilos? So, going to new technologies. So this is an idea. We have to combine the proton arcs with upright positioning and then shoot through protons. So what happens here that you still utilize the Bragg peak inside the target, but you can use the shoot through protons to actually get the very sharp penumbra along the edges. And as a plus, you have a single beam dump of the shoot-through protons, and the range detector here, so you can directly measure the range of your protons while delivering. And this is one of the results. We have a poster here at ESTRO that you can look at. So you have the full dose distribution to the left, which is very conformal for this head and neck patient. And here is the shoot-through part, which really circles around the CTD here to sharpen the penumbra. And for this patient, we get around 40% of the protons going all the way through the patient, and they can be utilized for the range detection. And we have in total over 1,500 spots, and from all different directions. So eventually you have a probe of the difference in anatomy. You could do even more, so you can do only shoot-through protons, and this is what Tony Lomax would like to coin as the protons. So this is like a photon machine in a proton setting. You just utilize the plateau, and of course then your proton machines will be very versatile. You don't need the photons alongside. So this is the example where we compare a shoot-through dynamic arc in this case, so constantly rotating while delivering, to the VMAT. Here is the dose difference, and more importantly, looking at the DVHs for the CTD, you see that the protons is very sharp here, while you have this one here. And also, you see a reduced dose compared to the VMAT plan. You could of course do all of this also with ions. If you do it with protons, you can do it with carbon ions, you can do it with helium, and start looking at arcs. If we take it one step further, of course, we can combine many different ions. And this is actually starting to happen now. You can change your ion source in a very short amount of time. And this is research ongoing in Japan, Italy, and in Austria here, where you actually do helium, carbon, oxygen combined plants, so multi-ion plants, and then combining that into an arc, you get like a record of degrees of freedom, where you actually can utilize all these degrees of freedom to shape the dose, and most important, the LET distribution. So this is the dose distribution, and then the LET distribution, which for some tumors it's very beneficial to get the high LET inside the tumor for the ions. And then, of course, there will be a split which is taken care of in the optimization, which ion will come at which place. So you see the helium part, which is more close to the proton, where you have a quite homogeneous dose. You don't have the scatter and the fragments, so that's really nice. And then you put some more carbon, which is sharper, around the edges of your secondary CTDs, and really inside the primary CTD you use your very high LET oxygen. So this is really something that I think we will see on ion clinics implementing the chair. It will not be a commodity like the proton machines, but still extremely interesting for some tumors. Then we can also think about these helical treatments. So this is an example with photons for pediatric patients. So instead of using 3 different VMAT beams, as this patient was planned with before, we can now instead use one single beam, and you see how the MLC here is shifting. The patient is moving upwards while we deliver this field, and we can do that in one single delivery and one single optimization. And of course we can apply this for all different modalities at the end. Going on to the very high energy electrons, a project we're working closely together with the CHUV in Lausanne. They have a high energy beam coming in here, and then if you put a chair here, you can start to get the different beam angles. With a high dose rate, you of course get the flash effect, that's what they want, But you can also think of doing this with conventional dose rate, rotating the patient at the same time, and get a VHE arc. So what they did study was to actually do a combination between this VHE flash and the VMAT plan. So doing a combination of the conventional dose rate and then the flash part, and then the combined one has a good dose distribution. And this is just to utilize both the flash part but also get it conformal with the VMAT. Of course, what you could do is to replace the VMAT by the VEE arc. So now I also have like a universal machine that you don't need to combine the different modalities in the same. Another interesting topic is, of course, the spatially fractionated treatments. So this is one example where you want a uniform dose in the target, but you would like to have the peak and valleys in the entry. So this is one of these examples where you see the line dose from this part, and you see the entrance from the different directions. While in the tumor you see that the dose distribution is still homogeneous. So this is different from the lattice technique where you want also to have peak values in the tumor, but this could be a very good way to spare the normal tissue. And what we did was to just place clusters of different spots separated by 1.8 centimeters and starting to optimize from all the different directions. But now when having all the directions, it's sufficient with this kind of spacing to get the good dose distribution in the middle. So I end by that and say that, I mean, you have many good potential with the upright for the future of radiotherapy and new technologies, and we can unlock that with this new system. Thank you.